Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
The following question refers to Section 7.3 of the 2025 ACS Guidelines. The question is asked by Thomas Jefferson, medical student and CardioNerds Academy Intern Dr. Grace Chu, answered first by University of Michigan Fellow and CardioNerds FIT Ambassador Dr. Kayla Secrest, and then by expert faculty Dr. Sunil Rao. Dr. Rao is an interventional cardiologist, professor of medicine at NYU Grossman School of Medicine, deputy director of the Leon H. Charney Division of Cardiology, and the director of interventional cardiology at the NYU Langone Health System. He is the editor-in-chief for Circulation Cardiovascular Interventions and was the chair of the writing committee for the 2025 ACS Guidelines. Dr. Rao, it is an honor to have you with us.
Gosh, thanks so much for having me. It's an honor to be here.
So first up, we have a 68-year-old man with a history of hypertension, hyperlipidemia, stage 3 chronic kidney disease, and prior tobacco use presents to a local emergency department with reports of chest pain while raking leaves at home. Upon arrival, he is hemodynamically stable with a heart rate of 86 beats per minute and a blood pressure of 133/85. His EKG reveals ST elevations in the septal and interior leads V1 through V4. He is given 324 milligrams of aspirin and is promptly evaluated by the interventional cardiology team, who elects to take him emergently to the catheterization lab. Upon arrival to the catheterization lab, the nurse asks the interventional fellow which access sites they should prep for this case. How should the interventional fellow respond? Option A, right radial artery only. Option B, radial and bilateral femoral. Or option C, bilateral femoral only.
The correct answer is B, radial and bilateral femoral. Radial artery access is the preferred vascular access site for coronary angiography and PCI patients with ACS. Transradial access has been shown to reduce mortality, bleeding, and vascular complications compared with transfemoral access. This is a Class 1 level of evidence A recommendation. Radial access also allows earlier ambulation and is associated with greater patient comfort. Although the right radial artery is the most widely studied upper extremity access site, alternative sites, such as the ulnar and distal radial arteries, have demonstrated similar outcomes. However, the radial artery may be required as a bypass conduit for CABG. In institutions where the radial artery is routinely used for surgical grafting, this potential future use should be considered when selecting vascular access. In addition, transfemoral access, preferably performed with ultrasound guidance, should be considered in patients in whom temporary mechanical circulatory support is anticipated, or in those for whom radial access is not feasible due to anatomical or technical constraints. Prepping bilateral groins, in addition to the radial artery, provides a backup strategy for urgent MCS placement or for transition to femoral access should radial access fail. For these reasons, prepping both the radial artery and bilateral groins is the most appropriate response. Radial-only preparation is incorrect because although radial access is preferred, patients with STEMIs may still require emergent MCS or an alternative access if the radial artery is unsuitable. Preparing only the wrist without backup femoral access may delay care should hemodynamic instability occur. Femoral-only preparation is incorrect because transradial access provides superior outcomes in ACS, including significant reductions in all-cause mortality, major bleeding, and vascular complications. RCTs and meta-analyses, including the Matrix, which showed lower MACE and net adverse clinical events with radial access, and Safari STEMI trials, which showed no difference in mortality but was underpowered, support radial as first-line access when feasible. So what is the main takeaway here? For patients with ACS undergoing PCI, radial access is strongly preferred to reduce mortality, bleeding, and vascular complications. Dr. Rao, I would love it if you have any additional thoughts or would like to expand on this particular guideline further.
Yeah, thanks so much. It's a great question. And I think you really summarized the data well. In the revascularization guidelines, a radial approach was mentioned for the first time in any guidelines document. And based on the trials that you mentioned in acute coronary syndrome, the comparison of radial versus femoral has shown a reduction in vascular complications, bleeding, as well as mortality. And that's really what led to the Class 1 recommendation in the guidelines. In the acute coronary syndrome guidelines, we basically transferred that guideline recommendation from the REVAS guidelines into the ACS document. one of the fundamental kind of principles of writing the guidelines documents is that unless there are compelling new data to refute or change a prior guideline recommendation, we really carry it forward. And I think that the data have been pretty definitive with respect to the benefit of radial access over femoral access, particularly in patients with acute coronary syndrome.
That's incredibly helpful. Drawing upon your experience, are there common scenarios that you find yourself crossing over from radial to femoral? And if so, what factors are leading up to that decision?
Yeah, that's a great question. Years ago, SCAI put out a document on best practices for transradial procedures. And in that document, there was a decision algorithm about when you should consider switching vascular access sites from radial to femoral, particularly in the setting of ST segment elevation MI, largely because of the door to balloon time metric. I think that the crossover rates really have gone down over time. If you look at kind of national data, as the adoption of radial approach now is exceeding 75% in the United States, people are becoming really, really facile with it. And the crossover rates, which occur really for three major reasons. It's either failure of access, failure to traverse the arm, or failure to seat the guide catheter. All of those things tend to improve with experience. The other thing that I think has led to a decrease in crossover rates is that now there are long vascular access introducer sheets that can go from the radial site all the way into the ascending aorta. That basically mitigates subclavian tortuosity and facilitates catheter manipulation. So I think crossover rates have gone down. Now, when would we consider crossing over? I think the major issue that really causes people to cross over to femoral access is radial artery spasm, which still is an issue. You generally tend to encounter it in small statured individuals who have small radial arteries. And so, if you're doing a radial procedure and the patient is very, very uncomfortable because of pain from manipulating the catheter, that's really kind of what causes people to switch over to a femoral access approach. And I think that's entirely reasonable. The whole reason that we do radial approach is that it's a safer, more comfortable approach for patients. So if patients are uncomfortable, it's really kind of negating the benefit of that. And that's where you would consider switching.
That's incredibly helpful. You had mentioned kind of the smaller stature for certain patients leading to a crossover. Are there certain ECG patterns or patient variables that would make you shy away from even starting radial and just going femoral?
I don't think so. I don't think there's anything, when you examine the patient, if there are no radial pulses, obviously it's complicated. But I think a lot of us are using ultrasound access now. One thing that I will tell you related to the short stature is that there have been 2 papers now that show that patient height below 5'5" a left radial approach will lead to a decrease in femoral crossover rates and a much faster procedure because of less subclavian tortuosity on the left side. So I don't think it's anything clinically that would lead someone to use a femoral approach. I think it's more really about the dimensions of the patient, with one big caveat, which is that if you really think that this patient is in, SCAI stage B or C shock, and you're thinking about going to mechanical circulatory support, either during the case or you're worried that you may need mechanical circulatory support as a bailout, you might want to consider going with a primary femoral approach because you're going to need that femoral access site for the MCS.
That's interesting. You mentioned left radial. Are you ever exploring other upper extremity arteries?
Yeah, good question. I mean, the other 2 possible sites are the distal radial, which is in the anatomical snuff box, or ulnar approach. Distal radial really was in vogue probably about 2 years ago. And there have been some randomized trials that have compared distal radial with traditional proximal radial, showing that distal radial reduces the risk of proximal radial artery occlusion. The challenge with distal radial is that it is much harder to get vascular access in the anatomical snuff box. And in general, we recommend ultrasound guidance for any snuff box access because there is a little bit of tortuosity in the anatomical snuff box and the artery is a little bit smaller there. It can be very, very helpful for a left radial approach, which is ergonomically for the operator. Using the left snuff box is a little bit more comfortable. Ulnar approach also has several randomized trials to support it. There have been randomized trials that have compared ulnar with radial, showing that it is a feasible access site. There's a slightly higher rate of forearm hematoma with ulnar access, largely because it's deeper in the arm and it's a little bit harder to get hemostasis after the procedure. I think in contemporary labs where ultrasound guidance is being used, oftentimes we will ultrasound the radial artery as well as the ulnar artery. And if the ulnar artery is much bigger, in other words, the dominant artery, we'll just go ahead and use an a priori ulnar artery approach.
Wow, that's excellent. Thank you so much for expanding.
Thank you so much for tuning into this CardioNerds episode. The audio editing for this episode was performed by me, Grace Chu. I'm an intern in the CardioNerds Academy House Jones and medical student at Thomas Jefferson University. Check out the episode page for show notes and references. If you found this episode or show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episode. And now, my friends, it's time to make like an S2 and split.